At Connecticut Eye Consultants, we never stop pursuing perfection. As a cataract center of excellence, we offer patients the most advanced diagnostics and surgical techniques available today, and we have been for over 30 years. We're innovators in laser and lens implant technology and are dedicated to helping our patients enjoy a lifetime of the best possible vision.
I think that cataract surgery has taken a quantum leap since I started doing surgery back in the early 1980s. When I first started to do cataract surgery, we would take out the whole lens, we would replace their correction with very thick George Burns-like glasses. Patients would have image jump, they would find it hard to walk downstairs. And as it's progressed into the intraocular lenses and now to these premium lenses that provide a range of focus, patients end up much better off than they did before they even had their cataracts, in that they're less dependent on using glasses. And it's been wonderful for them. And there are wonderful choices we can make in a variety of ways.
I'm practicing for myself mainly, from the sense that I enjoy what I do. I'm very gratified. I think being a physician, specifically in the practice of ophthalmology, is extremely gratifying. You can see the visual results. Most people are happy. I would say that we can improve the vision in more patients today than we ever could in the past. It's exciting, the innovation. I'm a visual person. I can see what's going on, and I'm enjoying it. And as long as my health continues, I would like to continue to take care of patients as I have at this point 2 days a week. Back when we had our 35th anniversary, we were all asked to put down a line or two that described us. And the first line was, in my 35 years of practice, I don't believe there was a day that I got up that I didn't want to go to the office. And I still feel that way. And the other person who is happy that I'm continuing to work on an abbreviated basis is my wife.
I think there's been a huge focus on cataract surgery and lens implants, partly because there's a larger and larger population requiring or considering cataract surgery. Patients have a more active lifestyle, so patients are opting to consider cataract surgery at a younger age because they need to do the things they want to be able to do in life. And all these lens implant options that are available now give them the flexibility to do the things they want to be able to do and the type of vision that they want for themselves for the rest of their lives.
This is a really exciting time to be a cataract surgeon. When you talk about what I can offer to a patient today versus 15 years ago, I mean, it's no comparison. There are newer technologies that are coming out every year. As far as patient outcomes, I would say the best people to ask about that are honestly the patients. I can tell you that in the right situation, with the right anatomy and the right testing, I can fairly frequently get a patient out of glasses entirely using laser surgery or an advanced technology lens.
It's an exciting time to have cataract surgery. 10 to 15 years ago, everyone got the same implant. We didn't have choices. Today, patients have choices as to which implants go into their eyes. The implants are permanent. We never go back and change them. And so it's important that patients understand their options. We educate our patients about their different options. That's an option for their eye. Cataract surgery is exciting because many patients have worn glasses their whole life, and this is their first time at freedom from glasses. The most common cause of falling are actually bifocals or progressive eyeglasses, and so depending upon the implant that patients choose at the time of cataract surgery, they can decrease their dependence on reading glasses or on bifocals or progressives.
Unlike in the past where patients would go through the surgery, cataract surgery, just for the visual improvement and to continue to wearing glasses, we can now customize to the individual's needs. If someone would like to see better medically and is comfortable with glasses, that's our approach. If someone wants to customize and have a approach which includes reducing or eliminating astigmatism, reducing or eliminating bifocals, all of that could be done. We partner with our patients to get the best outcome.
This is a very exciting time to be a cataract surgeon. Even as a glaucoma specialist, cataract surgery is my most common operation, and I do perhaps some of the most challenging cases, but it's very exciting. We really have new technology to really adapt our surgery to what the patient needs. We have different lenses depending on what they're looking for, and again, the more options we have, I think the more satisfied our patients will become.
At Connecticut Eye Consultants, we specialize in the treatment of astigmatism, which can be corrected in a number of proven methods. These include toric lens implant correction of astigmatism, surgical correction of astigmatism with limbal relaxing incisions or LRI, laser-assisted cataract surgery. Our eye care professionals are specially trained to diagnose your level of astigmatism using the latest breakthroughs in diagnostics to select and utilize the safest and most effective treatment method for your eyes.
So when it comes to astigmatism, I will tell you that patients kind of get an understanding of it when I describe it as the difference between having an orange and a lemon. And if you cut an orange in half, you end up with a nice dome, almost like the Duomo in Florence, or the top of any great cathedral. If you take a lemon and you cut it in half, you end up with a kind of footballish type structure, kind of more like the top of a stadium, and that is really what an astigmatic eye is, more lemon shape. And I think the beauty of modern cataract surgery with astigmatism correction is that we can truly make lemonade out of lemons. We can take that structure, understand where it's based, whether it's in the lens or in the cornea, and then replace the lens, which will balance the effects of the astigmatism that's left, so that a patient will get a crisp focus and really get the type of vision that will give them an optimal chance to really appreciate all that's out there.
Presently, in the right patient with the right testing and the right counseling, you can take care of their cataract, which is a removal, and then you can replace the lens with a lens that will take care of the astigmatism and potentially give them good vision at distance and intermediate, maybe even at near. It's all about understanding what you're expecting going in. And that's what the cataract consultation process is about. A patient who loves to ski is very different than a patient who loves to build model airplanes. And so when I meet you for a cataract consultation, I always say like the same kind of basic series of questions. Tell me about you. Tell me about what you do. What do you do for work? And then what do you do for fun? There's no reason to fix your distance vision for shooting targets if you've never held a gun. And so my patients that play golf want something different than my patients that ride bikes. It's not a one-size-fits-all approach. It's actually custom cataract surgery at this point.
Many patients today have astigmatism. They may not be aware of it, but it's corrected in their glasses or their contact lenses. At the time of cataract surgery, we can permanently correct this astigmatism with toric implants. Toric implants are fabulous because they give you a clarity of vision that can't be achieved even in eyeglasses. If astigmatism is not corrected at the time of cataract surgery, you're going to be dependent upon eyeglasses or contact lenses for the rest of your life to correct that astigmatism in your eye.
Honestly, getting your eyesight back is a gift, and if we can enhance that gift by reducing their need for glasses as well, and that's the patient's goals, it's, as I say to my patients, it's the same operation, just a question of which implant we're using for them. It has to be personal.
So a multifocal lens implant, the beauty of it is it gives you a broader range of vision, both distance and reading, intermediate, but it works very differently than having a progressive lens for glasses where it's very difficult to adjust to the glasses, or some people have a difficult time adjusting. Here, it's within the eye itself, it's in the natural position of your lens, so it's much easier for patients to adjust to it and have that flexibility and range of vision.
Today, of course, we've had a significant improvement in the intraocular lens implants. It used to be that cataract operation back in 1972, when I did my first cataract operation, the patient was in the hospital for approximately 3 days. We used about anywhere from 7 to 10 sutures. And now we have patients, my wife is an example of one, who is back home in approximately 4 hours from the time she left her house, having had her cataract surgery. Along with that, the implants have improved. The implants that we have today are excellent for correcting astigmatism. I think presbyopia, which is trying to have a situation where you can have a lens that helps you to see in the distance as well as up close, is a little bit more difficult. You never say never, and you never say always in ophthalmology, but it would be hard to imagine that we're going to get as good as God's creation. But I think that technologically speaking, we've come a long way in the last 8 to 10 years in getting patients to see clearer, quicker, and better and more naturally.
Well, the wow factor with the modern implants is great. Patients are waking up, they are seeing clearer, better than ever. We do have our patients understand that there's a healing process and that there'll be continued improvement. We usually describe 1 month as a typical time to full recovery, but day by day, week by week, they get better. It puts a smile on patients' faces. Often we'll do one operation and I'll say, let's see how you feel after the first one, and of course we'll do the second operation if you're interested, and within a day or a week they're interested in scheduling the second procedure because they've really gotten that wow factor so quickly. Cataracts come on very slowly over many years. We can reverse it in a matter of days and weeks, and the colors, their experiences, the way they see the world is a much more youthful type of experience. And once one eye is done, so many patients want to get the second eye done quickly.
What glaucoma is for the layman or for a patient would be, the colloquialism we use is the sneak thief of sight. It doesn't really have many symptoms until it's in the more moderate to severe stages, which is why, for example, a patient with a family history of glaucoma would see me at 45 and we'd be able to catch them at 48, as opposed to somebody who has no idea and they might come in at 70 and I said, this has been here for a long time. As far as the vision is concerned, glaucoma is mostly a peripheral vision problem. And so if you imagine a tunnel, right? That's what a patient with severe glaucoma can see through, a tunnel vision. They wouldn't be able to see the periphery very well, and the severity of the disease does end up being quite variable as to when I see those patients. As far as pressure is concerned, technically speaking, glaucoma is a chronic optic neuropathy, meaning a chronic change in the nerve that's related to, but not exclusively due to, the pressure in the eye. Now, if you imagine your eye sort of like a grape, right? If there's no pressure in it, it would shrivel up and it would look like a raisin. If it's too much pressure for your eye, what happens is that the nerve in the back of the eye, which is like the video cord out of your camera or your cell phone, gets asphyxiated, and it loses your peripheral vision first, and eventually it will affect your central vision. Now, unfortunately, that's irreversible, and that's the part that is really why I get so aggressive and so passionate about finding patients early. I cannot bring back what's already gone.
I'm very proud. It's probably the thing I'm most proud about. And that, as well as my relationship with the patients over 25 years, is the most satisfying aspect of my career. With glaucoma, you really do want to diagnose it early. The reason is, if changes or damage occurs, it's irreversible. So we want to stop that. And we've done everything we can to bring in state-of-the-art technology, technicians, a whole team approach to how to do this, to get patients in. And it's not only me, it's all of the doctors here. Everyone examines people for glaucoma. If they do have glaucoma or there's a suspicion they do, they can send them over. We have the state-of-the-art visual field machines. We have imaging machines that have really shown to be a way to really pick up glaucoma early, even before the traditional visual field test shows damage. So we've really made an effort to pick people up early, get them in treatment if needed, but to at least follow them. It's a very exciting time. We have more tools to offer patients. With glaucoma, you really need to lower the pressure. So we have more medicines now. In fact, our practice has been involved with the study of many of the medicines we're using. We have more surgical procedures that tend to be safer, which is very important to the patient. You know, the post-op course, we have patients that have very busy lives, and this has an easier post-op course, but very nice results. And as a surgeon, it's very exciting. I've had to develop new skills and learn new procedures that I think are worthwhile to our patients. And now we have a whole menu of options where in the past we didn't. So it's a very exciting time for us as providing surgeons and for our patients.
I think it's always been a great time to be a surgeon, but it's an exceptionally great time to be a glaucoma surgeon. It seems like almost every 6 months there's something new on the horizon. And as far as patients go, listen, there's no question, it's never good to have glaucoma. But if you had to have glaucoma today versus 25 years ago, I'd pick today. Since I finished fellowship in 2017, I've started doing at least 5 new surgeries. There's been new medications on the market. There are new laser treatments that we can do both in the office and in the surgical center. And the goal of everything that we're doing in that space we call minimally invasive glaucoma surgery. So I love it. Surgically, it's where I get the most joy, because what I can do is I can make it so that at the time of cataract surgery, or even sometimes without cataract surgery, whereas we would have had to undertake a major operation for the eye with all the attendant risks and benefits of that, we can sometimes really hit a home run with something that the patient doesn't even notice on their daily life. And you know, it's really kind of awesome.
So patients come from all over the state and beyond the state, even beyond this country, to come see us here in Danbury. Many times they have family in the area, but many times they find us on the internet through our credentials that are seen online, and they decide to come. I have some patients who come in from the Caribbean and fly in multiple times a year just to see me because they need specialized retinal care. And the care we provide here at Connecticut Eye Consultants is for everything, not just retina. It's from the front to the back of the eye, every subspecialty you can think of, at its most state-of-the-art way. So we have all the imaging technology, all the interventional medical and surgical ways to help retinal and non-retinal diseases here at Connecticut Eye. So patients really don't need to travel very far if they're local, and many of them who are farther away decide to come seek us out from many distances.
The best outcomes are still achieved with prevention. However, we've made big strides in the treatment, and I wouldn't use the word cure, but the treatment of macular degeneration and diabetic retinopathy. The numbers are not as rosy as we would like them to be, but way better than what it used to be in the 80s and 90s, where there truly was no hope. Now at least we can stop the progression of the disease in a vast majority of patients with wet macular degeneration. Yes, it entails injections, but at least we have something to offer them. Same applies to diabetic eye disease, what we call diabetic retinopathy. We were never able to improve their vision. At the very best, with laser and surgery, we could stop the progression of the disease. It's been a paradigm shift in treatment, how these injectables now are improving patients' vision and stabilizing a disease that was blinding in half the patients, half the cases. So I'm an optimistic person by nature. I tell my patients there's always hope. There's always hope no matter what. Results with dry macular degeneration are not as good as wet macular degeneration. We still don't have much to offer the patients other than the vitamins to slow it down. But a diagnosis of macular degeneration used to be a blinding sentence. Well, not anymore. I tell my patients, you're not going to go blind from macular degeneration. You may not be able to drive. You may not be able to watch TV. But hey, you're not going to go blind from this, or unlikely to go blind. It would be very rare because these treatments can achieve great success or great improvement in their vision.
After medical school, you have to go to ophthalmology residency and vitreoretinal surgery fellowship. So it's a long road to do really a very, very minute, specialized part of the body. But the retina, though it's a small part of the body, is very important, obviously. The retina, in my opinion, is really one of the most important parts of the eye when it comes to preserving and having good vision. And the medical and surgical aspects of treating patients who have those kinds of diseases is what I found most fascinating. And yeah, I could have done anything, of course. The world was open in that way. I think all medical students have that ability to say, well, what do I want to do when I graduate and want to specialize in? But as I told you before, my main focus, my reason for going into it was the experience I had as a medical student. And I just followed through.
Patients with macular degeneration, they can blame or thank their parents for the genes that they inherited from them. Let's face it, probably close to 80% of macular degeneration is genetically determined, and the rest is lifestyle and environmental factors, and in terms of diet and smoking. But for the most part, for the large part, it is genetic. It's a genetic disease. Let's face it. It's primarily prevalent in the Caucasian population, more so than other ethnic or racial groups. And It runs in families. We call it macular degeneration because it only affects the macula. The macula being the center part of the retina. I mean, it's defined by physicians. There's truly no clear separation between the macula and the rest of the retina. So it's something that's defined by physician surgeons as the macula, which is the central part of the retina. But this is where the disease is. Contrary to diabetic eye disease, which affects the rest of the retina, as well as the macula. So diabetic eye disease is something, diabetes may be affected by genes, but after certain years or decades of diabetes, unfortunately, even in patients who are well controlled, in whom the diabetes is well controlled, we could see signs of diabetic eye disease. It's not, while we feel sometimes powerless when it comes to macular degeneration, in terms of prevention, with diabetes is quite the opposite. The best treatment for diabetic eye disease is still prevention. While macular degeneration is more prevalent in the Caucasian population, diabetic retinopathy or diabetic eye disease can hit any population or any subgroup of patients. But more so in the Latin American countries and Hispanics and the Native Americans, diabetic eye disease is a worse problem than other populations, and the African Americans, of course. And that goes hand in hand with high blood pressure and hypertensive retinopathy.
Clinical research at Connecticut Eye Consultants has been performed for many years now. And by doing so, we've helped the FDA-approved drugs that have helped individual patients, which has helped society as a whole. We continue to be intimately involved in many clinical research trials for aspects of the eye from front to back, including retina, which is what I do. And by doing so, it's helped many patients, helped society, and continues to do so. So not every private practice has to do research. In fact, I would say only the minority of them do. Most people have the perception that research is only done in major institutions in large cities, under universities. And though they are done there, we're happy to say that for many years now, we've been doing cutting-edge clinical research here. Personally speaking, I've been doing research since I was an undergraduate, where I had many grants accorded to me, research grants to do biochemistry research. I carried that through to medical school, where I did continue to do clinical research through residency and fellowship, and I've been doing active research from bench to clinical for 20 years now. So I find it exceedingly important to be able to offer that to patients. I made it my mandate, as many of us here have, to include that as part of the repertoire of what we offer patients. Because no doctor has all the answers now. We're actively looking for the answers to come so we can offer it to our patients sooner.
We have state-of-the-art equipment, latest technology, latest approach, wide field imaging, and in the operating room we were at the forefront. We were the first adopters and adapters of sutureless technologies, sutureless surgery with 25 gauge, 23 gauge, and soon 27 gauge. We were the first ones in the area to shift to an outpatient ambulatory surgical center almost completely for our surgical retinal cases. And on top of all that, we have a very busy research department, and we're part of multiple national, multi-center major studies for retinal vein occlusions, diabetic retinopathy, macular degeneration in both forms, dry and wet, as well as uveitis, which is inflammation of the internal parts, layers of the eyes. We certainly are at the front line of technological advancements and medical availability and knowledge and being part of larger networks offer us the best tools to tackle the cases or the difficult cases of macular degeneration and diabetic retinopathy that we encounter in our community here. We're always looking for new ways to treat our patients, to offer them, albeit a glimmer of hope, because I do love what I'm doing, and it's truly a passion, or my passion. I always wanted to be an ophthalmologist, so I find it here at Connecticut Eye Consultants, with all the research that we're being part of, and the publications that we work with different centers, be it Yale or practices in Manhattan, that we are offering the best care, the best passionate care that could possibly be done in an outpatient community private practice.
quality of our vision and peripheral vision will decline as we develop a little droopiness and sagging of the upper eyelid skin. Many people don't become aware of these problems until their vision has been restored with cataract surgery, and now all of a sudden they don't have to wear their glasses. They're looking at themselves for the first time in many years without glasses. They start to notice the extra skin, the little heaviness of the eyelid. They may be aware of unconsciously raising up their eyebrows to try to get their eyes more wide open, or even sometimes lifting up an eyelid with a finger. And they come to me saying, why am I doing all these things? What's going on? And I explain to them how their eyelids are impacting vision. So functional eyelid surgery means we are trying to restore the normal functioning of an eyelid. So be it an upper lid blepharoplasty, which consists of removal of some skin and fat from the upper eyelid, our motivation is vision. With aging, many people experience a redundancy and a thinning out of the upper eyelid tissue, like the skin, and it can hang over the edge of the eyelid. When it does so, it decreases their contrast, which is a quality aspect of vision, and it will start to decrease their peripheral vision or their side vision, which could become an issue for driving, reading, sports, or some other hobbies. So functional surgery, the technique is the same as for cosmetic surgery, but our primary motivator is restoring a better quality of vision and functioning of the eyelid. Lower eyelid surgery to restore a better contour of the lower lids is also called a blepharoplasty. It can be, and it's very commonly done at the same time as the functional upper eyelid surgery, but it's always considered cosmetic. There has to be an art to your touch. There's so much that goes into just the planning of the markings for where you're going to put your eyelid crease incision, because if you make it too high or too low, it will really drastically affect the patient's appearance. So you have to respect the patient's underlying anatomy. You have to know the limitations of what you can do too, to make somebody still appear natural and have a natural result. I don't think it has that much to do with gender. Women will pay a little bit more attention to how much skin and fat you leave back, and you certainly don't want to remove too much tissue in a man's upper eyelids, because you don't want to make them look, altered or like they've had surgery. Men really want to look very like nothing happened, because typically they feel a little bit, uncomfortable having any kind of eyelid surgery, even if it's functional in nature in the first place. So those are some of the considerations that come into mind between women and men. So the typical cosmetic eyelid surgery patient will be a little younger and usually a little bit more well-informed, having done some research about different providers in the area and different techniques. But the basic surgical tenets and techniques are the same as with functional surgery. The planning of the eyelid incision. With my cosmetic patients, I make absolutely certain that I understand what they're trying to gain in appearance. Sometimes I ask them to bring in old photographs. We consult looking together in a mirror, and I tell them realistically what things can be achieved and can't be achieved, because I want there to be a high patient satisfaction. I want to be able to deliver what they're searching for. The majority of patients will elect to go to the outpatient operating room, the ambulatory surgical center, because then they're given a little bit of sedation and the whole experience is very comfortable. With a straightforward upper eyelid blepharoplasty, if there's not much fat decompression, we can do that under local anesthetic in the office, but most patients elect for just the comfort of going to the operating room. Botox is a very common cosmetic procedure. It's a nice, minimally invasive office procedure with no downtime. It's fast to do. The ideal patients are on the younger side. The way that Botox works is it weakens the muscles of facial expression in the face. So the very common areas to treat are the frown lines between your eyebrows, forehead wrinkles, the crow's feet, which are the lines that emanate when you have a nice big smile. But in order to prevent those creases from deepening or even forming in the first place, it's best if the patient is on the younger side. There are plenty of older patients seeking Botox, and there can be tremendous gain in treating these patients as well. But the sooner that you do Botox, you're going to reap the benefit of the wrinkle prevention aspect of it. And what's nice about Botox and fillers and these minimally invasive in-office procedures is that they can complement any surgical procedure we do on the eyelids, whether it's functional or cosmetic. So with Botox, if it's strategically placed in the face, you can cause a little bit of elevation of the eyebrow, which can help further open up the eyes and improve the eyelid appearance. Other surgical procedures that I commonly perform are repair of lower eyelid malposition. So some elderly people will get a abnormal relaxation or rolling outward of the lower eyelid, which is called ectropion. When it rolls inward, that's called entropion, and these are nice procedures with a high success rate to fix the problem. And I do some brow lift surgery if an eyebrow is very droopy. There's several techniques that can be done to address that. And again, that's usually done in conjunction with some sort of upper eyelid surgery. I do lacrimal surgery, so I see many patients who have tearing, abnormal amounts of tearing, and there are many, many different causes for abnormal tearing, but I will do a thorough evaluation to try to get to the bottom of it. And sometimes a surgical procedure is in order, and typically that has a very high success rate in resolving the problem. I do skin cancer removals and reconstructions of eyelids. Sometimes I work with local dermatologists or even plastic surgeons on some of these surgical cases.
You should actually come and have your ears checked around the age of 50 for the first time and have a baseline hearing test. This way we have data so that we can compare to as you mature. Typically people do not think they have a hearing loss because it is happening gradually. They're unaware as to what extent they're missing out. And it's usually their spouse or their family members who notice first. They may say something. If it gets to the point where your friends are telling you, it's probably pretty significant. Definitely the sound quality has improved. The hearing aids are very natural sounding. So even when someone comes in with a fairly significant hearing loss, I usually put hearing aids on their ears after I test their hearing and let them listen to me explain their hearing test while they have the hearing aids in. And they can't believe how clear I sound and how normal I sound. And it's not until I take the hearing aids off their ear and they now realize what their hearing loss sounds like that they have that aha moment. Oh, okay, that's how I've been hearing. You sound like you have a pillow over your mouth. So the thing about hearing loss is generally most people can have normal hearing in the low frequencies and hearing loss in the high frequencies. So they hear most things easily at a normal volume level, but it's the clarity that they're missing. They're missing the sounds when someone is speaking, and if you think about S's and TH's and T's, how often are they in the English language? So their brain is trying to fill in the gaps with things that seem to make sense when they're having a conversation, but then they misunderstand what they're saying because they mishear the word and their brain inserts a word that's not correct. Bluetooth technology is a wireless way to connect to other devices. So hearing aids in the past needed an intermediary device, whether it be a neck loop or a clip that you wear, so an additional item to charge in order to achieve this connectivity. Now hearing aids can connect directly, so your phone rings, you answer it like you normally do, the sound comes right in your ears, and you can have that conversation with people. You hang up like you normally hang up. If you are a little bit more tech savvy and you like to listen to music, you play music on your phone, it comes in your ears. So you can put your phone in your pocket and listen to your music. Or you can download audiobooks and listen to an audiobook through your hearing aids. And they connect to TV, Bluetooth, without an intermediary device as well. So when you come in for an eye exam, they do a quick hearing screening, and if they find that you have a hearing deficit, then you come to see me and I'll do a more comprehensive hearing evaluation. If during that evaluation I find that you do indeed have a hearing loss, then I will program a set of hearing aids for you at that time and put them on your ears so you can hear the difference for yourself between how you're hearing and how you should be hearing. Sometimes I even have my patients take home a trial set of hearing aids for a week or two to help them to see what it's like in their own hearing environments, at home with family and friends, out at restaurants, to help them to make the decision that works best for them. Restoring hearing loss can be a game changer. For people who have more significant hearing losses, I've put hearing aids on them and they've actually been brought to tears in the chair because they didn't realize to what extent they were missing out on speech and clarity. Their family relationships are so much easier when they can hear. People don't realize that when they have a hearing loss and they're having a conversation with someone, they're sitting forward and they're all tense. When they can hear clearly, they sit back, they relax, they enjoy the conversation. They have a much easier time following the events. And most events that happen within the family dynamics, they're on the spot. So if you miss it, it's gone. So it's best if you hear it the first time.